Thank you very much, Gina. First of all, of course, congratulations with your 10 years anniversary. And let me express the hope that there will be many more years to come with all the good work you're doing. And thank you very much for being present, for having me there at the birthday party. I enjoyed very much. I learned a lot already. And I'm happy to present some work that we've been doing with the Cochrane Review Group. As a Cochrane Review Group, we look especially at interventions that can improve health and safety at work. So it's slightly different from the work Regina is doing for the field. It's more focused on insurance medicine, but we have a little bit broader view and include all kind of occupational health and safety interventions, and we want to find out if they are effective. Well, here I will present the results of some work that Christina Tika has been doing. She's a PhD student of ours, and we have supported her together with Regina and Jan Hoving. Let me first talk a little bit about the problem. The lack of coordination is to be assumed to be a risk factor for a longer time of return to work. The idea is that when people are off work, there are so many different stakeholders involved, and they all have their own approaches, that this will lead to lack of communication, lack of coordination, and people will stay off work unnecessarily long. So this has been noticed in Finland as well, and the Ministry of Health and Social Affairs has instated a program on coordination of return to work. The idea behind the program is that the employer, occupational health staff and employee sit together in a meeting and discuss whenever it's necessary how they can increase the workability of the employee. So it's not only about sick employees, but it's about any employee that would have a reduction of their workability. And Finland is a well-organized country, maybe not as nicely organized as Switzerland, and certainly not as rich as Switzerland, but at least as well organized as Germany. So they invested a big sum of money in a program to implement return to work coordination in all possible companies and occupational health services. Then what happens is that Regina's team did a review on return to work coordination involving a coordinator from outside the workplace, and we published the results in 2017, and the result was, let's say in plain language, that this doesn't work, that it's not effective. And since I was paid by the Finnish Institute of Occupational Health to publish the review and to do the editorial work, you can imagine that my bosses at the Institute, which is a government research institute, weren't pleasantly surprised. On other occasions, one of the bosses said, well done, Jos, but please, next time, provide positive results. So it is a bit problematic that we find negative results, and especially because the Finnish ministry has implemented a lot of effort in doing this. And what should now the advice be based on this review? Should we now stop this valuable implementation program, continue doing it regardless of the results of the review, or even actively de-implement what has been implemented before? And that is the topic of my presentation. We wanted to find out how should you actually advise the stakeholders when you have the results of such a review in a way that it's not perceived as threatening, or in a way that it's perceived as this is a nice way of approaching the problem. And it's certainly a problem. Well, we looked at the implementation and de-implementation literature, and as you may be aware, the implementation of low-value healthcare is something that has been more and more practiced in healthcare. There's, for example, the American Choose Wisely program, where they list interventions that shouldn't be used anymore. And the question is, of course, can we do something similar for our reviews? Well, one of the points of departure and more difficult issues to assess is what actually the current practice is in the country or in the jurisdiction where you're located. Is that what they're doing in Finland at the moment? Is that now exactly the same as they have been studying in the studies in the review? As you may know, negative results, especially from systematic reviews or authoritative studies, are usually approached by people who don't like the results by saying, what we are doing is completely different, so the results don't apply to us. So we felt that it's important to find out what is exactly done in Finland and to what degree it has been implemented, and is it similar to what has been evaluated in the studies, because that would be convincing in saying, yes, the results of the review also apply to Finland. And then, of course, this conclusion that I presented to you, there is no effect, is a very rough type of conclusion, and there's always margins of certainty and uncertainty. There is something with the quality of the evidence. So we have to be sure that the results of the review present the best possible evidence that we could get. And once we are sure about these two steps, we can apply what is called an evidence to decision framework. It's been made also for different types of decisions. For example, the Moberg 2018 has been developed to come from evidence in a systematic review to a decision about public health interventions. And we would say this is certainly a public health intervention, what you do here. Well, actually, there are sort of basically 4 or 5 steps. And the first step is, of course, to balance the desirable effects, reduction of sick leave, with possibly undesirable effects of the intervention. Does the intervention any harm? Because when there is considerable harm together with the desirable effects of the intervention, and we are unsure if it actually works, even a little bit unsure if it still might work or not, and there are harmful effects, then the decision is much easier. The second criterion to make a judgment is to make an assessment of the resources that are used for this intervention. And for example, for an intervention like coordination of return to work, that wouldn't be immediately clear. And it would be good to have a little bit more detailed calculation of the resources used and maybe a cost effectiveness or cost benefit analysis. Then it would be important to assess if the intervention helps to improve equity or helps to decrease inequity, because there's many big variance in equity in healthcare. And of course, the other steps are the acceptability and the feasibility. But for this intervention, you would say that's apparently clear, but it's because it has been implemented already on quite a large scale. But let's have first a look at the current practice in Finland. Is it now similar with what has been studied in the review? And that's not an easy question, because if you want to know about the implementation of interventions in healthcare or in practice or in public health, the information is not readily available. It is something that you have to dig up from expert interviews, from government reports, statistical sources, and it was actually quite a lot of work to find out what actually the content of coordination of care in Finland was. And we compared that the coordination of care in Finland, which had as a content that the worker, employer, and the physician sat together in a meeting, in a physical meeting, and then discussed the possibilities of return to work. We found out that it was actually quite similar to being studied in the systematic review. And mostly in studies, they use the term coordinated care, similar as in Finland. But sometimes there is also something called like case management, would be slightly different, or consultation. But finally we concluded that it's undeniable that what is used in Finland is similar what has been evaluated in studies. Then you would say, is the setting in Finland, is that similar to what has been studied in the review? In the review, in all studies, all workers were on sick leave for at least 4 weeks before this coordination of care was invoked. But in Finland, actually, it's a bit unclear because this concept of coordination of care is much wider than only sick leave. And actually only 50% of the workers were, over 50% of workers were not on sick leave longer than 4 weeks. So we conclude, okay, it's mostly similar, but slightly different. The studies were done between 1995 and 2012. The information in Finland was at a slightly later period, but we felt that it was mostly similar. The participants, worker, employer, physician, other stakeholders possibly, were very similar in the studies in the reviews in Finland. Also the content, consisting of a face-to-face meeting, a worker's needs assessment, a return to work plan, and then the implementation of the return to work plan was very similar in Finland and in the studies in the review. And also the intervention duration was a bit unclear because we couldn't find out how long these return to work meetings were continued in Finland, but we found that this was a sort of minor detail. So in our first assessment, we felt that we had quite clear evidence that current practice in Finland was very similar to the practices that have been evaluated in the systematic review. So the argument, what we do in Finland is different, wouldn't hold up. And then we looked at the results as presented in the review. And here you immediately see why it is important to have a core outcome set. Because the return to work was measured in the review, but we had 4 different outcome measures. There were 6 studies that measured the time it took to return to work. There were another 6 studies that looked at the proportion of participants at work at the end of follow-up. Another 6 studies looked at the proportion of participants that ever returned to work. And then again, another 8 studies looked at the cumulative sickness absence that people had after the intervention had been applied. And the problem is that if you want to combine the results numerically, it's not possible with these different outcomes. Well, it's possible, but we figured that this would be a very blurred and fuzzy picture, so we presented them separately. Now, the quality of the evidence was also assessed for these different outcomes. How well were all these studies conducted, and how well was the body of evidence that underpinned these outcomes, how high quality was this? And yeah, unfortunately, as is often the case, most of these outcomes are only underpinned with low quality evidence because of high risk of bias in the studies, because the results were not very precise, items like this. I have pictured the results of the review in what you would call a forest plot, and then you can immediately see what they look like. Here the vertical line is the line of no effect. Would it be to the left of the line, no coordination would be favored. Would it be to the right of the line, then coordination would be favored. And as you see, time to return to work, there is a very large confidence interval. It could be beneficial for no coordination, and it could also favor, to a very large extent, coordination for return to work. The proportion of people that return to work at end of follow-up was much closer to the line of no effect, and there was only a 6% increase, but still not statistically significant. The proportion that ever returned to work, and that was underpinned with moderate quality evidence, was even closer to the line of no effect, but still it can't be excluded that, for example, there was a 10% increase of workers that ever returned to work during the intervention condition. And also when you look at the number of sick leave days, it gives you the best impression of how beneficial this intervention could be, then you can see here that the average across studies was minus 14 days, but the uncertainty ranged from extra almost 10 days to a beneficial effect of minus 40 days. So the results were not very precise, and we can't exclude that, for example, there's still small beneficial differences, even though they are not statistically significant in this review. What does this now mean for the criteria on to come from the evidence to a decision? Well, the first one was balance desirable and undesirable effects. And here, we concluded there's no desirable effects, but we didn't find any undesirable effects. There's clearly no harm involved with coordinating return to work. So this wouldn't help us much further. Then there is an important item, resource use, and we could calculate how much the coordination of return to work meetings in Finland would cost, and what would be the beneficial costs of a reduction of sick leave. And then, because sick leave is so expensive and return to work coordination meetings are, well, relatively short and not very expensive, we could easily calculate that a small reduction of days in sick leave would already be cost beneficial. In terms of the review, it's beyond the certainty of our results. So it could easily be that there is still a small reduction of sick leave that is not captured by the review, and that could be cost beneficial. The equity argument, we felt that it didn't hold very well here. Return to work decreases inequity. Helping people to return to work, I think, is very beneficial in increasing health inequities. So it's only good to do this. And the acceptability and feasibility of the intervention were also good in Finland. So what conclusion to draw here is not really easy. A good thing is that we could say the Cochrane review results also apply to Finland, but there's still uncertainty about the evidence, and we would actually need, or would like to see, a very large, high-quality randomized control trial that could exclude or could confirm that there is still small effects that would be cost beneficial. But given the situation where this is being implemented, it is highly improbable that we can convince decision makers to do such a review, to do such a randomized control trial. So I think we have to deal with the effects of the intervention as they are presented in the review, and we feel, or at least I feel, that it's improbable that this will soon be improved. So would that then mean that we should say to Finnish decision makers, so the unions, the employers, the government, that they should de-implement this? We felt that this was a bridge too far, and that the uncertainty surrounding the effects and the lack of undesirable effects, there's no big harm done, potentially, do not warrant de-implementation. But we would say to them that they better stop active implementation, because it might easily turn out that it is a waste of money until further evidence becomes available and the results are more certain. So we've just finished this, and we hope to represent this to Finnish decision makers, and we're very curious to see what they're going to say. In previous attempts to involve, for example, unions and employers in this type of decisions, we had very complicated feedback. For example, when we showed to unions that training workers in proper lifting techniques didn't work. They said, but we negotiated with the employers that this is a very good intervention, and that we have obtained this intervention in tough negotiations, so we're not willing to stop doing this, even though they knew that it didn't work, and they agreed that it didn't work. So the implementation in our field might be much more complicated than it is in the area of clinical medicine, but certainly something to further study and find out. This is what I wanted to tell you. Thank you for your attention.